I'm Dan Pollier from the University of Colorado, where I direct the leukemia service, and I'll be moderating today's tumor board. And I'm joined by some of my colleagues from around the country, and I'll let them introduce themselves, starting with Dr. Kamdar.
Hi, my name is Manali Kamdar. I'm an associate professor at the University of Colorado, and I lead the lymphoma program there. Glad to be here.
Hi, Tyler Fromm. I'm an assistant professor of radiology with appointments in both abdominal imaging and nuclear medicine at the Washington University School of Medicine in St. Louis, Missouri, and I'm happy to be here as well.
Hi, I'm Michael Thurman. I am an associate professor at the University of Chicago, section of hematology oncology. I focus on hematologic malignancies and in particular leukemias.
The chronic phase CML. So these, as we know, CML has been revolutionized by tyrosine kinase inhibitors, but there are still some challenges in this field to discuss. So this is a 60-year-old male with CML and chronic phase. Unfortunately, has a T315I mutation and has progressed through multiple lines of therapy. Currently on omacetaxine, which we'll talk about. So the question we're going to address is, how do you manage a patient such as this who is either intolerant to or progressed after multiple TKIs? So at presentation, originally the patient is asymptomatic with a performance status of 1. That's not that uncommon with CML, where it gets picked up just by some routine lab screen that shows, an elevated white blood cell count with, various myeloid forms in various stages of maturation. So you've got a bunch of eosinophils and basophils and metamyelocytes and promyelocytes, and you sort of see the whole spectrum. And when you see that in combination with a normal to elevated platelet count, you can sort of start to put the story together even without the definitive testing of what you're going to be dealing with. This patient does have some comorbidities: hypertension, stroke, seizure, chronic renal insufficiency, no other relevant social or family history. So, this patient was originally diagnosed 10 years ago and has kind of been through a variety of different treatments. So this patient received the original first-generation therapy, imatinib, and then on to all 3 of the second-generation drugs that we have, nilotinib, dasatinib, and bosutinib. So we don't know too much about what went on with those different therapies, if they were poorly tolerated or resistant from the disease. But unfortunately, in 2017, this patient develops an accelerated phase CML, and bone marrow biopsy shows the T315I. So, Dr. Thurman, you've been practicing for a little bit, so you kind of know what things were like pre and post ponatinib in the field, and give us a sense of sort of how important this particular gatekeeper mutation has been, and how significant ponatinib is.
Well, so this is a complicated situation, and we know that the first targeted therapy that was effective in CML is now about 20 years old. That was the development of imatinib, and that was really viewed as a major milestone in CML and also Philadelphia chromosome positive ALL, and really changed, I think, the field of oncology. And what we learned is that most patients do well, but some develop either intolerance or resistance, and we have the second generation tyrosine kinase inhibitors, so nilotinib, dasatinib, bosutinib, and this patient's received all 3, which is pretty remarkable. And then we found out a few years ago that really the Achilles heel of the tyrosine kinase inhibitors was the T315I mutation, which is resistant to imatinib, nilotinib, dasatinib, and bosutinib. And the TKI ponatinib was developed, and fortunately that can target this mutation. And the downside to ponatinib is that it has a very high risk of stroke and cardiovascular events, much more so than any of the other TKIs. We do see some vascular complications with nilotinib and perhaps with some of the other TKIs at a much, much lower rate. Now, in this case, he developed an arterial stroke and then, was taken off and switched to omacetaxine. And it says that, he did well for a few years. But now we're really starting to exhaust our options here. It also now, of course, if allogeneic stem cell transplant was an option, this would have been done presumably already in a patient like this. It says his only donor options are his children, who are haploidentical, of course. So transplant would be the best way to go, but that seems to be excluded. So the question is what to do now. So there is a new drug that's been developed, asciminib, which can target ABL through a different mechanism than the standard tyrosine kinase inhibitors like imatinib and the group that this patient's received. So if this were possible to obtain for this patient, I think that would be the clear next step. And I'm not sure where it stands in terms of FDA approval, but once it is commercially available, I think that would be for sure the way to go in a patient like this, since it's the last drug that hasn't been tried and we know has considerable efficacy. There are a couple possibilities just to think about here. So it would be important to check with the ponatinib whether or not the patient was on either aspirin or anticoagulation at that time. If not, it would be possible to consider resuming ponatinib with aspirin or a TKI, with the understanding that there still would be a high risk for a cardiovascular event, but certainly the progression of this accelerated phase CML would be very concerning. Another possibility would be to consider a lower dose of ponatinib. There are some people who will respond to lower doses than the initially approved dose. So those are some things to think about. So even though this patient's been through 1, 2, 3, 4, 5, 6 lines of therapy, I think there still are a couple more things that could be pursued.
That's great. Thanks so much. That was very thorough. I mean, I think, omacetaxine has the potential to overcome T315I resistance, but in this case, if this has been this patient has been on this treatment for a considerable period of time, still having a BCR-ABL transcript level of 5.3 is not near the level of a major molecular response that we would want. It's also just omacetaxine is more difficult to be on than a pill, so it's not always a long-term plan. But yeah, I totally agree with your strategies around considering a lower dose of ponatinib with more aggressive cardiovascular optimization versus really trying to see if there's access available to that asciminib yet, or just getting some insight into how soon that might be available, because I think that is a drug that can overcome T315I as well. So, I mean, I think just to summarize, for these very challenging sort of end-stage CML patients who develop T315I mutations, trying to mitigate the cardiovascular complications of some of the TKIs like ponatinib and or reduced doses is a viable strategy. As Dr. Thurman said, reconsidering all transplant options and re-evaluating candidacy for that versus looking into this new asciminib, which we're excited to have hopefully at our disposal in the near future.